So our next speaker is Philip PEYTON from Australia, and he's going to talk about fluid management. Philip?
Lovely. Thanks, Andre. Look, thanks for the opportunity to present the results of the RELIEF trial. This may be the first presentation outside Australia. I'm not sure. I'm not sure if Paul Miles has already done this at another venue, but certainly it was presented in Sydney a few months ago and has just been published in the last couple of months. So I only have one conflict of interest to declare. It's loosely related. I have a IP in non-invasive cardiac output monitoring. It's only loosely related to what we're going to say. So look, over the course of my career, I think I've seen these sorts of trends happening in the way that we approach fluid and haemodynamic management of our patients during major surgery. When I was a young fella, your first response to hypotension was just to turn up the drip and give more fluid, basically. And then you would supplement it with some vasopressor, but it was always fluid as first line. And there was a common apprehension that patients were often going to the wards or becoming volume depleted and dehydrated post-operatively. So we felt that giving patients plenty of fluid perioperatively was a good thing. But over the subsequent years, there was a growing concern that indiscriminate use of particularly crystalloid was bad for patients that were fluid overloading patients, and it was leading to tissue edema, and that may have adverse consequences, particularly for patients having major abdominal surgery and bowel surgery, where tissue edema may in fact impair the anastomotic healing process and wound healing process and lead to complications. So we moved more towards targeted use of colloid with just background crystalloid for volume repletion. But the idea of restrictive fluid management being superior to traditional liberal fluid management gained a lot of traction, and over the last several years or more, I've seen many of my colleagues priding themselves in turning off the drip post-induction and running the patients on what I would have thought to be very little fluid intraoperatively and also post-op. Then on top of that, there's the more sophisticated argument about the use of goal-directed fluid management to actually use measured variables, targeting these variables to use fluids and vasopressors and whatnot in a more targeted and intelligent way. So it's quite a complicated and messy topic, this, and I'm going to try and keep this as simple as possible because the RELIEF trial is a simple trial. So there have been numerous small trials in this field done over the years. The particular issue that we're going to be discussing here is the question of, is restrictive fluid management superior to liberal fluid management in terms of outcomes in patients having major abdominal surgery? And that was the particular focus of the RELIEF trial. So as I said, this has become quite a popular and quite entrenched part of ERAS protocols. So the notion of avoiding fluid overload has really become locked into the package of care which ERAS contains and which has become widely adopted throughout the world, and including in Australia. However, there have been up until now, no large randomised controlled trials to tell us whether restrictive fluid management is in fact better for patients. They've all been small trials, but nevertheless, as is our habit in our field, there has been meta-analysis and there have been many conclusions drawn from these small trials, and concepts of this being best practice has sort of started to creep into our lexicon. And I just want to say a few words about that. So we have numerous meta-analyses. The staple diet of meta-analysis, of course, is small, single-centre randomised trials. And these are very different from large effectiveness trials in all sorts of ways. The level of evidence that they provide, I say, is questionable. And you need large randomised trials, multi-centre trials, to get reliable evidence for any major clinical question like this, I believe. The reason for this is because if you take a step backwards from this particular topic and just look at the ability of meta-analysis in perioperative medicine to predict the outcome of a later, large randomised trial, the performance of meta-analysis is dismal. The positive predictive value of endpoint outcomes in meta-analysis in our field is around 20%. The negative predictive value of a meta-analysis outcome is much higher. It's about 88%. So a negative meta-analysis is quite a reliable predictor of a negative large trial outcome, but positive results in meta-analysis are generated with undue ease due to all sorts of factors, and the biggest factor is publication bias, basically. Positive publication bias is the killer, and it's possibly the greatest flaw in the entire meta-analysis and, dare I say, the Cochrane philosophy, because it's almost impossible to deal with in data analysis. I won't pursue, in the interest of time, I won't pursue that topic, but it's an important background to the results of the RELIEF trial. So Michael Bellamy, in an editorial about 10 or 12 years ago, I think crystallised this clinical question about how much fluid is the right amount. And he created what we call now the Bellamy curve, which plots fluid load on the x-axis versus outcomes on the y-axis. And we're looking for this sweet spot at the bottom of the curve. Now, where that sweet spot lies is the big question. Does it lie to the left with restrictive fluid management or further to the right? And that was the question really that we were looking to answer. So the RELIEF trial was, the hypothesis was that a restrictive fluid regimen in major abdominal surgery would lead to reduced complications and improved disability-free survival. And I'll talk about that as an endpoint in a minute, compared with a liberal fluid regime. And the study population was going to be a typical population having major abdominal surgery, elderly with associated comorbidities, and I'll outline those in a second. And very much a multi-centre randomised, partially double-blinded, because it's not an intervention that can be fully double-blinded, and pragmatic randomised trial. Targeting these sorts of 24-hour fluid volumes, about 2.5 to 3 litres in the restrictive group versus 5.5 to 6 litres in the liberal group. The inclusion criteria are listed here. I won't go through them in detail, but this is major abdominal surgery expected to last at least 2 hours with a hospital stay of at least 3 days. A wide range of operations, open or lap-assisted, and with those comorbidities. So a moderately high-risk population, the sort of population that you need to study, not only because it's the most clinically relevant population, but because it's the sort of population that will have a sufficiently high baseline incidence of the complications and outcomes of interest for us to be able to generate statistically significant outcomes from our data. The exclusions were few. We excluded patients who were dialysis dependent for obvious reasons, and we excluded patients having liver surgery because there are specific fluid management issues in that particular group that are separate to the issue that we're addressing here, which is more to do with really bowel surgery largely. So the protocol was a fairly simple and practical one. The restrictive group were going to get a intravenous crystalloid bolus of less than 5 ml per kilo on induction, and then 5 ml per kilo per hour intraoperatively, and then post-op less than 0.8 milligram per kilogram per hour. So we expected to see less than 3 litres less than 3 litres in the first 24 hours in the restrictive group. In contrast, the liberal group would get a bolus of 10 ml per kilo on induction, 8 ml per kilo per hour post-op, and then at least 1.5 ml per kilo per hour for the first 24 hours. And as a general management rule, the response to hypotension in the restrictive group was to give vasopressors first and then fluids second, and the opposite in the liberal group, fluids first and then vasopressors second. All very consistent with routine care, really. But all other principles of ERAS management of patients was expected, and was encouraged. You know, we are believers in ERAS as a general principle and in the perceived improved outcomes that we're seeing in our patients that are associated with that, and we're just addressing this one particular part of the ERAS package, really. So early ambulation, early feeding, and multimodal analgesia were all encouraged. So the endpoint that was measured was disability-free survival. So this is the new concept, which is actually the baby of Paul Miles, who was the PI for the trial. It's very much a longer-term and patient-centred outcome. So there are other analogous outcomes to this. So days alive out of hospital is another example of this and is becoming quite widely used. So it's looking beyond the 30-day window towards more important patient-centred outcomes. And the definition of this was a persistent reduction in functional status measured using the 12-item HUDAS as the scale and a 4-point change. So clearly defined outcome, but very much different to the traditional 30-day outcomes that we've previously used. However, we still were interested in all these shorter-term outcomes. So septic complications, surgical site infection, anastomotic breakdown, pneumonia were all important secondary outcomes that were studied. Renal outcomes, ICU admission, length of stay in hospital, quality of recovery were all routinely studied as well, as we always do. Pulmonary edema, cardiac outcomes. The sample size calculation based on data published, particularly from some UK data, which suggested a one-year mortality for open colorectal surgery of 17%, which is quite high actually, and some pilot data on the rate of disability-free survival and disability in this sort of patient group suggested that we're going to need a sample size of at least 1,300 patients in each group, which eventually was rounded up to 3,000 patients in total because the endpoint rate was a little bit lower at interim analysis than we expected to see. So in the end, 3,000 patients were recruited, which would give us 90% power to detect a 25% difference in complication rates. We were fortunate with our funding application, so this was actually the highest rated project grant application in the 2012 funding round for the National Health and Medical Research Council in Australia, which is our major funding body. This sort of substantial six-figure sum is the sort of sum that you need to do a large trial on this basis, and our track record has actually been quite good in achieving these large grants, and we were successful on this particular occasion. So over the next 3 years, recruitment was steady and the trial progressed well. We were approaching our target here at the middle of July 2016, where we had recruitments across 49 centres in several regions, and mainly Australia and New Zealand, but also the United Kingdom, United States and Canada. So a real fantastic team effort. Now the primary endpoint was a 12-month post-operative endpoint, so there's another 12 months delay after the last patient was recruited, and the database was cleaned up and locked in November 2017 and the results analysed almost a year ago now, and the results were presented at our ASM in May in Sydney. So, and published in the New England Journal just recently. So firstly, the groups were very comparable. As you'd expect in a trial of this size, major asymmetries between the two groups and any of the relevant possible confounding variables is highly unlikely, and there were no confounding factors that we ran across in the randomisation process. Importantly, the fluid balance targets that we set were pretty much achieved. So the median cumulative total for intravenous fluids in the first 24 hours was a bit higher than we thought. In fact, it was higher in both groups than we'd planned. So it was about 3.5 litres in the restrictive group and a bit over 6 litres in the liberal group. But a clear difference of 2.5 litres in the first 24 hours overall, with a separation of about 1.5 litres in 24 hours in fluid balance at 24 hours and weight gain as well. So we had aimed to achieve a 2.5 litre difference in fluid administration between the two groups, and that's what was achieved. So that's the most important thing to demonstrate in terms of the trial outcomes. Sorry, so this slide hasn't come up very well. This was supposed to be come in bits and pieces, but essentially the primary outcome, which is disability-free survival, there was no difference at all. It was 82% in both groups. The mortality rate was also similar, as was the rate of disability between the two groups. So restrictive fluid management produced absolutely no difference in the primary outcome at 12 months. The incidence of all the other secondary outcomes was also not different, except for two important outcomes, which I've highlighted in red. So first of all, the incidence of surgical site infection was lower in the liberal group. Now, this doesn't achieve statistical significance after you do multiplicity correction, a Bonferroni correction for multiple endpoint testing. But the raw p-value on that difference, which is a hazard ratio of 1.2, is 0.02. But the incidence of acute kidney injury, defined by NDIGO criteria, in other words, basically looking at creatinine change in the post-operative period, was significantly worse in the restrictive group. And that remains statistically significant even after correction for multiple testing. The incidence of renal replacement therapy was also higher, but once again, that wasn't significant after correction for multiplicity testing. But nevertheless, it's consistent with the change in creatinine that we saw between the two groups. So the bottom line here is that, in contrast to the predictions of all the previous small trials in this field that have been published, the incidence of surgical site infection appears to be worse with restrictive fluid management, and certainly renal outcomes are worse. There are no advantages to restrictive fluid management for the patients at all. This is the survival, Kaplan-Meier survival curve between the two groups. In fact, there was a marginally statistically significant separation between the two groups in terms of survival, disability-free survival, at about the 90-day mark, and then there was a catch-up effect out to 12 months. This is interesting because just what is the optimal sampling window to choose for longer-term post-operative outcomes? 12 months is a very arbitrary number, time to choose. Perhaps 90 days is the sweet spot in terms of looking for the impact of perioperative and intraoperative interventions in terms of longer-term outcomes, because of course everything eventually will become diluted by other confounding factors and just by people getting older and dying for other reasons. So if we're moving beyond the 30-day window for our outcomes, 90 days may be the place to start looking for the maximum discriminative power from our perioperative interventions. So look, relief answer to the very simple question, is less fluid better? The answer appears clearly to be no. The renal outcomes here are important. Now, there's a lot of questions that I have and that you might have about those. What are the influencing factors in terms of the risks of renal deterioration after surgery and fluid management? So things like, what are the predictive factors in terms of preoperative renal function? Is perioperative or intraoperative oliguria predictive of postoperative renal dysfunction? All those sorts of things. These will be answered in some subsequent secondary analyses. So there'll be another paper coming out, hopefully quite soon, which will look specifically at the renal outcomes. But certainly there's no evidence that the anastomotic or septic outcomes are any better with restrictive management. They're probably worse. But I can't prove that to you statistically with this data, just because of the multiplicity testing issue. In terms of the Bellamy curve, it certainly looks like the sweet spot is not to the left, it's somewhere to the right. So this, for me, where do we go from here? I'm a glass half full sort of guy, no pun intended. I'm basically asking the question, well, where do we go with improved and intelligent fluid management for patients? And I think the answer probably lies, we don't have to be worried about giving patients fluid anymore. We don't have to be scared of turning on the drip anymore. So the question is, how do we actually use the drip to improve outcomes? And to me, I think looking for an individualised and goal-directed or target-orientated approach is the way to move on from this point. We know that less fluid is not better. How do we use that more fluid? And once again, there's been several meta-analyses suggesting that goal-directed fluid management improves outcomes in patients. The data from the optimised trials is worth being aware of. So you may be aware of optimised. It was published a couple of years ago in JAMA. It was a large trial done in Britain, a multi-centre trial run by Rupert Pearce. They randomised 734 patients to goal-directed fluid management versus standard care. And the goal-directed algorithm was actually stroke volume optimisation using the LIDCO device plus low-dose dopexamine. And they found a substantially reduced rate of septic complications in the goal-directed group. The p-value on that was 0.07. Now, don't tell me this was a negative trial, okay? This is probably the world's best ever pilot trial, but it's leading on to Optimise 2, which is going to repeat that algorithm in a sample of 2,500 patients, and we're actually cooperating with this in Australia. There's a number of centres in Australia which are getting on board. They've already recruited 500 patients for Optimise 2, and that will tell us, in fact, whether the findings of Optimise 1, which strongly suggests that goal-directed fluid management is going to improve patient outcomes, is the way to go. And I guess watch this space. All right, thank you very much.